On behalf of the NIH Office of Disease Prevention, it is my pleasure to welcome you all to today's event from our Prevention in Focus webinar series. My name is Dr. Valerie Robinson, a health science policy analyst here at ODP, and I will be serving as your host for this session. As a background, this webinar series was first launched in 2021. It was created to provide a platform for hearing directly from prevention research experts and thought leaders whose work is driving impactful advances in the field of prevention research and public health. Today, we are pleased to have Dr. Amalia Peterson from Vanderbilt University Medical Center. She will be joining us today to present a window of vulnerability, menopause, and dementia risk. Before we begin, I would like to go over some logistics for today's session. As attendees joined the webinar today, audio lines were muted. These lines will stay muted throughout the session. Next slide, please. Please note that this webinar will be recorded and an archive recording will be available in the coming weeks on the NIH Office of Disease Prevention's YouTube channel. There will be a Q&A session at the end of the presentation, and as stated here on this slide, please feel free to send us your questions via the Q&A chat pod directly to hosts and panelists. And at any point, continue to submit your questions via the chat pod. Next slide, please. With that, I'd like to introduce Dr. Melissa Green Parker for opening remarks. Dr. Melissa Green Parker is a seasoned public health professional with over 2 decades of experience in biomedical research management, capacity building, and executive leadership. Dr. Green Parker currently serves as a senior program director at the NIH National Institute of Arthritis and Musculoskeletal and Skin Diseases. Dr. Green Parker also collaborates closely with senior leadership across the NIH to enhance accountability and improve efficiency in a rapidly evolving federal environment. Welcome, Dr. Green Parker, as she provides a brief summary of our Menopause Pathways to Prevention program. Welcome, Dr. Green Parker.
Wonderful. Good afternoon, and thank you, Dr. Robinson, for the opportunity to talk briefly about our recent Pathways to Prevention, or P2P program titled Advancing Research to Improve Health During the Menopausal Transition, and that took place in April of this year. As illustrated in the graphics shown here, this P2P garnered a broad level of interest with 8 supporting offices representing 2 HHS agencies. It boasts the largest group of P2P collaborators to date. Next slide, please. I'm not seeing the slides, so all right. Um, This P2P program is a multi-year collaborative workshop-based program that addresses prevention topics with underdeveloped research and broad public health importance. A typical P2P process includes 3 distinct implementation phases that span 3 years at minimum. And as we move through a structured process, clarity around the current state of science is obtained and an outline for a federal-wide research agenda to address the research gaps is produced. Can you click, please? The menopausal transition topic was deemed very important and timely because menopause affects over 1 million women in the United States every year. And as women age with grace, the menopause transition truly reflects an inflection point where thoughtful biomedical and biobehavioral research approaches can support the implementation of effective preventive health interventions. Furthermore, women experience menopause differently, And due to the influence of lifestyle factors, social determinants of health, and environmental exposures, the timing and onset of symptoms associated with menopause transition varies. Next slide. The centerpiece of the entire P2P program is the P2P workshop itself. Organized over 3 full days and centered on two key questions or KQs, the workshop format included core sessions that provided broader context, incorporated patient centered perspectives, and highlighted emerging areas of research. In addition to the core sessions, several experts and thought leaders brought their perspectives about what works for whom, what works, period, what works for whom, and when it works. And other presentations really centered on the systematic evidence report that was prepared by an AHRQ supported evidence based practice center. Moreover, audience engagement occurring over the course of the workshop elicited comments, questions, and open dialogue from the public. And all of this served as useful sources of information that the independent panelists are currently using to develop their draft report. Next slide. In this brief overview, I hope you've been able to understand that the P2P program is really one huge collaborative effort that identifies research gaps and ultimately encourages translation and dissemination of research findings. After all of the planning and sharing of evidence during the workshop, our team really continues to move forward in collaboration with other federal entities, and we refer to them as translational partners because they stand ready to pursue specific actions in the short, medium, and long term that will keep advances in menopause research at the forefront. Next slide. Future research addressing women's health is very central to the mission of NIH, and our focus now is to identify collaborative efforts with other federal partners to fill critical evidence gaps. The prevention.nih.gov website will be updated regularly to include workshop recordings, the independent panel's report, and the federal action plan. The life course framework that was presented at the workshop really helped to showcase the menopause transition as a key prevention window for long term mental and cognitive health. And so it's so fitting to have Dr. Peterson with us today because menopause and perimenopause are not just about symptoms. Addressing the long term disparities of access, healthcare delivery, health outcomes is truly managing overall engagement with care. It's truly about that management of engagement with care and understanding those risk trajectories. So, again, thank you for your time and interest. Please stay tuned as more outcomes from our P2P will be shared soon. And I'll turn this back over to Dr. Robinson.
Thank you, Dr. Green Parker. Next, I'd like to introduce our featured speaker for today's webinar, Dr. Amalia Peterson. Dr. Peterson is a behavioral neurologist and assistant professor of neurology at Vanderbilt University Medical Center. Her research examines how women's health factors across the life course relates to Alzheimer's disease and related dementias. She's a co-investigator with the Vanderbilt Memory and Aging Project and clinical core co-leader of the Vanderbilt Alzheimer's Disease Research Center. Dr. Peterson completed her medical training at the University of Michigan, residency at UNC Chapel Hill, and fellowship and a master's degree in epidemiology at Columbia University. The floor is all yours, Dr. Peterson.
Thank you so much. Thank you for inviting me to speak about the relationship between menopause and dementia. It's an area I'm particularly passionate about and where there is still a lot to be learned, I think. So I thought I'd start out with a couple of definitions. So dementia is this umbrella term to describe someone who's having trouble with their memory, language, problem solving, or other thinking abilities that is severe enough to interfere with daily life. There are different types of dementia that are based on the changes that are going on in the brain. So Alzheimer's disease is a type of dementia. It's the most common cause and makes up anywhere from about 60 to 80% of cases. There are other types of dementia. So vascular dementia, which results from cerebrovascular disease or impaired cerebral blood flow, Lewy body and frontotemporal dementia, which are associated with different proteins and different symptoms, and other types of dementia. And while we often think that these diseases occur in isolation, we know that co-pathology is very common, and cerebrovascular disease that causes vascular dementia is the most common pathology to co-occur with Alzheimer's disease. Neuropathologically, Alzheimer's disease is characterized by the presence of amyloid beta plaques and neurofibrillary tau tangles. The cognitive trajectory for someone with Alzheimer's disease is different from the trajectory of normal aging. So as you can see in the figure on the right, with this dashed line at the top, everyone has some decline in thinking and memory as they get older. In Alzheimer's disease, people develop mild cognitive impairment, which is characterized by greater than expected difficulties with memory and thinking for their age, that progresses to dementia, which, as I mentioned, is when problems with cognition become severe enough to interfere with daily activities and independence. We know that these proteins begin to accumulate decades before the onset of clinical symptoms. And so while we think about Alzheimer's disease as a disease of aging in the elderly, the changes are beginning decades beforehand, which I think you'll see in this talk has implications when we think about menopause and when that occurs in a woman's life. Alzheimer's disease is a public health crisis. It's very common. About 1 in 9 Americans over the age of 65 has Alzheimer's disease, and age is the biggest risk factor. So as the population ages, the total number of people living with Alzheimer's disease is increasing as well. Further, Alzheimer's disease is one of the top 10 leading causes of death in the United States. And there's a well-established sex difference in Alzheimer's disease prevalence. So of the over 7 million Americans living with Alzheimer's disease, nearly 2/3 of them are women. And women have about double the risk of developing Alzheimer's disease compared to men. So you can see in the figure on the right, at age 65, a woman has about a 20% risk of going on to develop Alzheimer's disease in her life as compared to a man who has just over a 10% risk. And we don't entirely understand why this difference exists. Women typically live longer than men, and so they have a higher likelihood of reaching the age where Alzheimer's disease becomes more common. Women may also live longer after being diagnosed with Alzheimer's disease, which could contribute to the observed higher prevalence of Alzheimer's disease in women. But I think there's evidence that it's more than just a survival bias and that there are unique risk factors for women. So there are sex-specific risk factors across a woman's reproductive life course. So menarche, pregnancy, and menopause, and the associated symptoms and treatment that I think relate to Alzheimer's disease and related dementias. And there's a lot of interesting work being done looking at pregnancy and other sex-specific risk factors. But for today's talk, I'm really going to focus on menopause. Increasingly, menopause is being recognized as this window of biological vulnerability to Alzheimer's disease. This graph is showing you hormonal and neurological changes that occur pre, during, and post-menopause. Estradiol, shown in the orange line, significantly declines during menopause when amyloid, shown in the green line, begins to accumulate. And loss of estrogen has been hypothesized to play an important role in women's vulnerability to Alzheimer's disease and related dementias. As I mentioned earlier, the neuropathological changes in Alzheimer's disease begin well before the onset of clinical symptoms. And so the time when the neuropathology begins to accumulate can be right around the time of menopause for many women. And here are just some of the many pathways through which estrogen could impact brain health, both directly through things like amyloid and tau regulation, and indirectly through changes in the vasculature. And I think understanding sex differences in Alzheimer's disease is particularly important now, as we are now in an era of disease-modifying therapies. So new amyloid targeting therapies are approved for the treatment of mild cognitive impairment and mild dementia due to Alzheimer's disease and seem to slow down the progression of the disease. There are 2 drugs on the market, and interestingly, there is some evidence to suggest that there may be possible sex differences in response to these treatments. So on the left is a subgroup analysis in lecanemab looking at males and females. And this is looking at the Clinical Dementia Rating Score, or CDR, which captures functional and cognitive decline. These are post hoc analyses, so the studies weren't designed to specifically look at sex differences. However, the data suggests that there is a statistically significant effect of these drugs on cognition outcomes in men, but that's less clearly the case in women. As you can see, the highlighted confidence interval kind of crosses that line in favoring placebo versus lecanemab. And with donanemab, the most recently approved drug, there is a statistically significant benefit in both men and women. So we don't see that same sex difference as we do in lecanemab. A third drug, aducanumab, which is no longer on the market, also showed this sex difference, suggesting women may not benefit in the same way that men do. So the jury is still out on whether women will benefit from these drugs when used in clinical practice, but it highlights that understanding sex differences in risk factors and disease presentation is clinically meaningful and important if we want to find effective treatments. So returning to the topic of menopause. Menopause is the permanent cessation of menstruation resulting from the loss of ovarian follicular activity with an associated decline in estrogen levels. The menopausal transition, or perimenopause, occurs after the reproductive years but before menopause, and is characterized by irregular menstrual cycles, endocrine changes, and symptoms like hot flashes. In the US, the average age of menopause for women is 51. Early menopause occurs between the ages of 40 to 45, and premature menopause occurs when women are younger than 40. Most women go through natural or spontaneous menopause. Artificial menopause, on the other hand, occurs as the result of a medical intervention that stops ovarian function. So this includes things like surgical removal of the ovaries, chemotherapy or radiation, or other medications. And unlike natural menopause, where there's a gradual decline in estrogen, with artificial menopause, there's an abrupt loss. The majority of women in the US experience symptoms during the menopausal transition. And interestingly, a lot of these are neurological. So 40 to 60% of midlife women report cognitive symptoms, such as forgetfulness, during the menopause transition. Mood changes like depression and anxiety, and sleep disturbances are also common. And so I think that leads to the question of, well, what's the significance of these symptoms? Are these the beginnings of Alzheimer's disease or other types of dementia? And the short answer is no. For most women, cognitive symptoms during perimenopause are not the first signs of Alzheimer's disease or another neurodegenerative disease. All women go through menopause, but the vast majority do not go on to develop Alzheimer's disease or other types of dementia. Subjective symptoms are not always associated with objective impairment on testing. When there is evidence of objective impairment, the domains that seem to be most affected are verbal learning and memory. But these tend to be relative weaknesses as opposed to being truly kind of below expectations. And it seems like these scores rebound after menopause. Despite the fact that cognitive symptoms are common during the menopausal transition, there are limitations to the work that's been done. And so the neuropsychological testing that's performed is often limited compared to studies of aging and Alzheimer's disease. Additionally, the follow-up time is relatively limited. In the United States, as I mentioned, women go through menopause on average at age 51, but the majority of women won't experience clinical symptoms of a neurodegenerative disease like Alzheimer's disease until decades later. And so it can be hard to follow these women for a long enough time to truly understand the relationships. So I've talked to you about Alzheimer's disease, which falls under the umbrella of neurodegenerative diseases that cause cognitive impairment. But there are also plenty of reversible causes of cognitive impairment that, when addressed, can improve cognition. These include things like poor sleep and mood symptoms, both of which are common during the menopausal transition. Neuroactive medications, things like pain medications or anticholinergic medications, and medical conditions, so things like thyroid abnormalities or vitamin deficiencies. And menopause seems to be another potential contributor. So it's complicated. Like I said, some of that can be attributed to things like changes in sleep and mood. And not all of the subjective symptoms of cognitive impairment cause objective impairment on testing. Though cognitive symptoms are typically not indicative of a neurodegenerative disease, I'm going to argue that there are brain changes that can occur during this period that make some women more vulnerable to developing dementia, even if that's not what is driving the symptoms at the time of the menopausal transition. So I want to show you the different brain changes that seem to occur during menopause, starting with brain glucose metabolism. So these are from studies looking at groups of women and brain glucose metabolism using FDG PET and categorizing women as asymptomatic premenopausal controls, perimenopausal women, and postmenopausal women. So looking at figure A, you're looking at FDG uptake in different regions cross-sectionally. And you can see that there's a stepwise gradient where peri and even more so postmenopausal women have decreased activity compared to premenopausal women in the temporal cortex, posterior cingulate cortex, and precuneus, as well as the frontal cortex. Figure B is a representative example of looking at the change of glucose metabolism over time in women who are going through different menopausal stages, as well as in men. And you can see that there are decreases in glucose metabolism, particularly in the frontal lobe, in women who are going through menopause. And we don't see that same change in men. So this data is suggesting that there is a shift away from glucose utilization during the menopausal transition. There are also sex differences in the neuropathological burden of Alzheimer's disease. So this is two different cohorts looking at amyloid and tau burden by sex measured on PET scans. Looking at the entorhinal cortex, which is part of the medial temporal lobe and interacts with the hippocampus, amyloid is on the x-axis here and tau signal is on the y-axis. And you can see that at low levels of amyloid on the left side of the graph, there are no sex differences in tau burden. However, in individuals who are amyloid positive on the right, there's a greater burden of tau in women compared to men. The reason for this difference is not clear, but often focuses on changes in estrogen. So it's been proposed that estrogen drives a more severe downstream response to amyloidosis, or that estrogen levels have a direct effect on tau. So it seems like women have more tau in the setting of amyloid. And interestingly, menopause status moderated the association between sex and tau PET. So you're looking at three different brain regions here. Women are in red, men are in blue, and each figure is comparing premenopausal women to men on the left side and postmenopausal women to men on the right side of the figure. Compared to age-matched men, postmenopausal women showed a greater tau PET signal, but there was no difference in premenopausal women compared to men. Of course, menopause doesn't occur in isolation, and there are other factors that can be contributing, but this could indicate a critical period of tau vulnerability in women that occurs around the time of menopause. So I've shown you that there's seems to be changes in the brain's energy source and the proteins that cause Alzheimer's disease that occur around the time of menopause. And if the biological changes that occur during this time potentially start you on the process of developing abnormal pathology, then earlier age at menopause could lead to a longer time for this pathology to accumulate and a greater likelihood to develop clinical symptoms. So this is a study that looked at age at menopause and risk of developing clinical Alzheimer's disease. In the Kaplan-Meier curve on the left, women are grouped into tertiles of menopause, with women who are over the age of 50 at the time of menopause in black, 45 to 50 in blue, and younger than 45 in red. And women with earlier age at menopause had a faster time to Alzheimer's disease onset. Additionally, compared to women who had menopause after age 50, women who had menopause before the age of 45 had an increased risk of developing Alzheimer's disease. This is a different study that looked at age at menopause and amyloid and tau PET. On the x-axis, again, is amyloid burden, and on the y-axis is tau, with women grouped into premature, early, and regular menopause. You can see that at low levels of amyloid, age at menopause didn't make a difference. But in the setting of high amyloid burden, with the cutoff shown in those vertical blue lines, earlier age at menopause was associated with a higher levels of tau, suggesting that women with early or premature menopause may be particularly vulnerable to tau deposition. And this fits with the idea that women with earlier age at menopause are at a greater risk for developing clinical Alzheimer's disease. Surgical menopause, which by definition occurs before natural menopause, could relate to Alzheimer's disease risk in a similar way. But there are also other factors, such as the abrupt loss of estrogen as opposed to a more gradual decline, or social factors, for example, why women are getting their ovaries removed, that could be influencing Alzheimer's disease risk as well. This is a study that looked at removal of the ovaries and risk of dementia and cognitive impairment. And they showed that there was an increased risk of cognitive impairment or dementia for women who'd undergone either unilateral or bilateral oophorectomy before the onset of menopause, compared to age-matched women who had not. The association was age-dependent, with the risk greater with younger age at surgery. And these women underwent oophorectomy for non-cancer indications, but the relationship persisted regardless of the non-cancer indication for the surgery. This is looking at the slope of cognitive decline over time in women who've had natural menopause, which is the line here in red, and hysterectomy, or removal of the uterus, at varying ages, with older age shown in orange here at the top, and then getting progressively earlier as you go down. And earlier age at hysterectomy was associated with a steeper slope of decline during the study, as well as a lower intercept to begin with, which the authors suggest indicates that there was a substantial amount of decline that had occurred prior to study enrollment. This is a study that looked at hysterectomy status and clinical Alzheimer's disease risk. And in this study, there was no difference in time to Alzheimer's disease or in risk of developing Alzheimer's disease in women who'd had a hysterectomy compared to those who had not. I focused on Alzheimer's disease and associated amyloid and tau neuropathology. But as I said at the beginning, co-pathology in individuals with dementia is very common. And cerebral small vessel disease, co-pathology, is common and associated with earlier symptom onset and faster decline in Alzheimer's disease. White matter hyperintensities are these bright spots that you see here on the MRI and are a marker of cerebral small vessel disease, and in and of themselves contribute to cognitive impairment. White matter hyperintensities exist on a spectrum from mild to severe. And we often think that when the white matter hyperintensities are very severe, that they can contribute to someone's symptoms. It's noteworthy that women tend to have more white matter disease and faster progression of disease than men later in life. But similar to what I showed you with glucose metabolism and Alzheimer's disease pathology, this sex difference in white matter hyperintensities seems to emerge later in life and is influenced by menopause. So in the figure on the left, with white matter hyperintensities reflected on the y-axis, women who are premenopausal show no difference in white matter hyperintensity volume compared to age-matched men. However, shown in the figure on the right, postmenopausal women in blue have a greater burden and accumulation of white matter hyperintensities compared to men. The white matter disease that you see on an MRI represents macrostructural changes. There are also microstructural changes that can affect cognition and are thought to often precede the macrostructural changes. This is showing you that there are a lot of different white matter tracts connecting various parts of the brain. And there are different ways of defining these tracts, measuring white matter integrity, and interpreting what these different measures indicate that can lead to some heterogeneity. This is one of the largest studies that has looked at sex differences in white matter microstructure longitudinally. And this is showing you that there are pretty diffuse sex differences in white matter structure in older adults. So in each of these tracks, a star indicates that there was a significant sex difference, with women showing lower fractional anisotropy compared to men over time, which we typically consider to be a marker of worse white matter structure. This study did not look specifically at menopause status, but this next study did. And this is a slightly different study. So it was included about 137 participants who were cognitively unimpaired, looking at how white matter integrity changed over the course of menopause cross-sectionally. The top 3 lines on these figures are getting at fiber density and thickness. And then that last measure, FA, is a measure of the direction of water diffusion, which is again indicative of microstructural integrity. So compared to men, premenopausal and postmenopausal women exhibited greater fiber density and thickness across most tracts, indicating denser and more organized white matter. However, you can see that during the menopausal transition, during that perimenopausal period, there are significant changes in white matter, with women's white matter structure looking more similar to men's during the perimenopause. I'll also point out that women had a higher FA in the fornix, an area known to be affected in Alzheimer's disease. In perimenopause, in premenopause, women exhibited greater FA, indicative of more organized white matter. Perimenopause, women exhibited lower FA, suggestive of a kind of a change in the white matter structure. And then postmenopause, that reverts back to a higher measure compared to men, again, suggestive of greater white matter organization and microstructure. So these results are cross-sectional and in a relatively small sample of cognitively unimpaired participants, but I think it suggests that there may be this transient window of white matter reorganization, particularly in Alzheimer's vulnerable pathways like the fornix, that occurs during menopause and could potentially inform Alzheimer's disease risk. We typically think of traditional vascular risk factors as driving white matter disease in the brain. So things like high cholesterol, high blood pressure, diabetes, and smoking. Women's rates of cardiovascular disease after menopause increase, presumably due to loss of estrogen's vascular protective effects. And so it could be that vascular risk factors are contributing to why we see this difference in pre as compared to postmenopausal women compared to men. However, vascular risk factors don't seem to be the only driver or explanation of white matter disease in the brain. So this is a graph on the right showing, or on the left, showing energy utilization. And I showed you earlier that there's a decline in glucose metabolism during the menopausal transition in women. And we have evidence of this in humans as well as in animal models. And so the solid line shows that there's a shift away from glucose as an energy source and a shift towards the use of fat as an energy source, shown in that solid black line, driven by the breakdown of myelin, resulting in white matter degeneration. And so the figure on the right is suggesting that as estrogen declines during menopause, there's a shift away from glucose metabolism and an increase in amyloid deposition and white matter degeneration, which results in an increase in Alzheimer's disease risk. And I'll remind you that estrogen touches so many different processes in the brain and in the periphery. And in addition to the direct impact on brain health through things like amyloid and tau and neuroinflammation, estrogen also exerts effects on the vasculature. So normally the aorta buffers the pulsatile force of heart contractions by expanding to accommodate systolic blood flow and then releasing blood flow during diastole to reduce pulsatile stress transmitted to the circulation. There are age-related arterial changes that lead to increased arterial stiffness, reducing the aorta's ability to buffer against these pulsatile forces. And these hemodynamic changes result in an increase in pressure transmitted to the cerebrovascular system that seems to result in damage. These age-related changes have been shown to be associated with reduced cerebral blood flow and white matter degeneration and cognitive decline. Estrogen promotes arterial compliance and cardiac output. And so at menopause, when women lose the vascular protective effects of estrogen and seem to experience greater downstream effects of arterial aging, which may relate to the loss of estrogen during menopause. We know that arterial aging is associated with brain health, but we haven't had a lot of studies looking at how these relationships differ by sex. So the next few slides are using data from a cohort that aims to assess cardiovascular contributions to cognitive and brain health in aging prior to the onset of clinical dementia. This is looking at pulse wave velocity, which is a measure of arterial stiffness, with greater velocity indicative of greater stiffness. And we see that increased stiffness relates to white matter hyperintensities in the temporal lobe longitudinally in women, but not in men. When we look at cardiac output, or how much blood the heart is pumping out, we also see a sex difference longitudinally. So in longitudinal analyses, there is a significant cardiac output by sex interaction for amyloid levels in the spinal fluid. So you can see here that lower cardiac output was associated with a decrease in amyloid over time in the spinal fluid in women, but not in men. And it's important to know that as amyloid accumulates in cerebral plaques, the levels of amyloid in the spinal fluid decrease. And so a decrease in amyloid in the spinal fluid over time is suggestive of amyloid accumulation in the brain. As tau becomes hyperphosphorylated, the levels increase in the spinal fluid. However, there was no significant sex interaction for phosphorylated tau and no association in either males or females. This hasn't been looked at or kind of broken down by menopausal status, but I think that's a logical next step. I'd like to switch to another potential contributor to white matter disease, which is menopausal vasomotor symptoms. So vasomotor symptoms are hot flashes and night sweats that begin during perimenopause and can actually persist well past menopause for many women. Over 70% of women report having vasomotor symptoms, and in nearly a third of these women, the symptoms are frequent or severe. There's research showing that vasomotor symptoms, particularly night sweats, are associated with greater white matter hyperintensity burden. Interestingly, this association is seen in physiologically detected vasomotor symptoms, but not in self-reported vasomotor symptoms. And this relationship doesn't seem to be explained by cardiovascular risk factors, sleep, estrogen levels, or depressive symptoms. And it's not entirely clear why the association is evident in physiologically detected vasomotor symptoms, but not in self-reported symptoms. It may be that women are underreporting vasomotor symptoms compared to physiological assessments, or it may be that these assessments are difficult in things like night sweats during sleep. We also see an association with levels of amyloid in the spinal fluid in relationship to vasomotor symptoms. And so women who experience more objective vasomotor symptoms have lower levels of amyloid in the spinal fluid, again, indicative of greater cerebral amyloid accumulation in the brain. So vasomotor symptoms seem to be associated with white matter hyperintensities and amyloid. And then the question is, does this translate to associations with cognition? The studies are mixed. So some studies show that there are cross-sectional associations with worse verbal memory, slower processing speed, and worse attention, whereas other studies show no association between vasomotor symptoms and cognition. There have been relatively few longitudinal studies. One did find an association between vasomotor symptoms and subjective forgetfulness, but is limited by looking at women primarily in their 50s. And so the long-term cognitive trajectories of women with a high burden of vasomotor symptoms is still not well established. This is a study that looked at self-reported vasomotor symptoms in women during their 50s, and then cognitive outcomes at ages 65 and 72. And this study found no association between vasomotor symptom severity and cognition at age 65, and there was also no association in change in cognition from 65 to 72. There are a couple of different possibilities for why this may be. So first, participants in this study had at least a high school education. And we know that people with higher education have cognitive advantages and perform better on testing and can tolerate more neuropathology. It also might be that participants were still too young to be experiencing significant cognitive decline yet. And so maybe the results would have been different looking at women in their 80s, for example. And then finally, this study looked at subjective vasomotor symptoms. And it seems like it's really objective vasomotor symptoms that are driving the associations with brain pathology that have been observed. And so while this doesn't settle the question, I think this provides some evidence that subjective vasomotor symptoms do not seem to impact cognition in women in their 60s or early 70s. So switching gears a little bit, back in the fall, there were lots of headlines about the FDA's decision to remove the black box warning for menopausal hormone therapy. And this was met with strong opinions both for and against the decision. And I think to understand the decision and the reactions, we need to go back about 30 years. So in the 90s, over 1 in 4 women was taking menopausal hormone therapy. 20 years later, that number has declined to just 1 in 20. And I will kind of preface the following slides by saying that I'm focused on the cognitive effects of hormone therapy, which is just one piece of the puzzle. So I'm not touching on other health effects of menopausal hormone therapy, like cardiovascular disease and cancer. With that being said, there were a series of observational studies and meta-analyses that came out in the 90s that suggested that hormone therapy reduced the risk of dementia. So in the figure on the left, individuals who had never taken hormone therapy were more likely to develop dementia compared to those who had taken it for a short period of time, so less than a year. And that difference was even more pronounced in those who had taken hormone therapy for over a year. Hormone therapy use or estrogen use was also associated with a reduced risk of developing dementia. And when looking at kind of combined studies, it was predictive not only for Alzheimer's disease, but other types of dementia as well. This thinking changed in the early 2000s when the Women's Health Initiative results were published. So this was a randomized clinical trial of hormone therapy, and they found that women on hormone therapy had about double the risk of developing dementia compared to those who were given a placebo. And this changed prescribing practices, but despite the fact that it changed prescribing practices, it was criticized for not necessarily being representative of women who were most likely to be prescribed hormone therapy. So first, these women were 65 or older, and most had gone through menopause over a decade ago, and they were not required to have active menopausal symptoms. Most women who are prescribed hormone therapy are prescribed it around the time of menopause for things like vasomotor symptoms. Additionally, the formulations that were used in this study are different from what is widely available today. And so many argue that the results from this study are not necessarily generalizable to current prescribing practices. But it did raise the question of why there was such a difference between observational studies and this randomized clinical trial. And it led to kind of two complementary hypotheses. So the critical window hypothesis says that the effects of menopausal hormone therapy depend on the timing of use relative to age at onset of menopause. And relatedly, the healthy cell hypothesis posits that estrogen exposure is beneficial for healthy tissue prior to neurodegenerative injury and harmful following neurodegenerative injury once neurons in the brain are kind of on this harmful pathway. Fortunately, follow-up studies have not found the same harmful cognitive effects that were observed in the Women's Health Initiative study. So a lot of these are kind of subsets of larger trials, and the WIMSY study, which was a subset of women from the Women's Health Initiative, found that when hormone therapy was initiated closer to menopause, there were no negative effects of cognition at follow-up in women who were in their late 60s. The KEEP study looked at women without cardiovascular disease, and again, women who were prescribed hormone therapy at the time of menopause, and found that both within a few years of follow-up and approximately 10 years later, there was not a significant difference in cognition. And then the last study looked at a subset of women within a larger trial and found that even pretty far out from menopause, there did not seem to be that same significant negative effect on cognition in women. And so I'm summarizing for you here kind of the overarching guidelines regarding menopausal hormone therapy that from the Menopause Society. So it should not be used in the prevention or treatment of cognitive decline, but it seems to be cognitively neutral in early natural postmenopause. And so for women who are less than 60 or within 10 years of menopause without contraindications for being on hormone therapy, it can be used for the prevention of bone loss and the treatment of vasomotor symptoms. Additionally, in the absence of contraindications, hormone therapy is recommended at least until the average age of menopause for women who have undergone premature or early menopause. So a couple of take-home points that I think are important. So most women who experience cognitive symptoms during the menopausal transition will not develop dementia. Those are not indicative of the beginnings of a neurodegenerative disease. However, during the menopausal transition, there are changes in brain glucose metabolism, Alzheimer's disease biomarkers, and white matter disease that may make women particularly more vulnerable to developing Alzheimer's disease or other types of dementia. And then lastly, there's been a lot of debate about menopausal hormone therapy, but for the time being, it seems like it can be prescribed for symptomatic women around the time of menopause without obvious cognitive harm. And so with that, I'd like to thank you all for listening, thank my colleagues at Vanderbilt, and again, thank the NIH for inviting me to speak and for providing funding that supports my work and the work of so many others.
Great. Thank you, Dr. Peterson. Great presentation. We do have quite a few questions rolling into the chat, but before we get into the Q&A session, I do want to go over a couple of ODP upcoming virtual events. The first being that we have a Mind the Gap webinar coming up on June 30th on Bayesian sequential designs and studies with multi-level data. Feel free to register for that. Next slide. And then also we have a couple of prevention and focus geared events. The first being a special event on NIH Rising Stars in Physical Activity, the research symposium. Look out for details on that. And next slide, please. We also ask that you join us on September 10th at noon for an unintentional injuries prevention and focus webinar topic. And now continue to put your questions in the chat pod. And as we transition to the Q&A session, I now welcome our moderator, Bob McNellis, who is a senior advisor for disease prevention and team lead in the Office of Disease Prevention. He leads the efforts to identify prevention research areas for investment across the NIH. And he also leads ODP's Pathways to Prevention program. Welcome, Bob.
Thank you, Valerie. Hey, I'm so happy to be here. And let me add my congratulations to you, Dr. Peterson. You're getting lots of hearts and claps and lots of compliments in the chat. Great presentation. This is such an important topic. I think many women, especially as they move into the menopausal transition, worry about cognitive decline, worry about the risks of Alzheimer's. And I think you highlighted a lot of important points. There are a ton of great questions in the chat. I just warn you, we're not going to get to all of them today. We're going to be tight on time, but let's start with a couple very quickly. I thought I'd just start with one that I thought was interesting that's come through a couple of different places, and that is, I think, I wonder about the diagnosis of Alzheimer's disease, in particular, sort of the sex differences. Do you think any of that has to do with the way women seek care out? Are they get diagnosed more because they go to their doctor more? Any indications that there might be some tricky ways around what that prevalence means?
Yeah, that's a great question. So I think you're right that women in general tend to seek healthcare more than men, and so there are more opportunities for cognitive screening and dementia or Alzheimer's disease diagnoses. I think a lot of the studies looking at prevalence don't are looking at kind of population-based studies that don't necessarily require an individual to present to their doctor to be diagnosed. And so I do think it's not just that women are seeking more medical care than men. I think the other interesting component is that women tend to perform better on tests of verbal memory, and this advantage compared to men, and this advantage is maintained in the setting of early disease. And so the testing of verbal memory is really important for determining um, the diagnosis of mild cognitive impairment and Alzheimer's disease. And so their relative strength in this area might actually delay their diagnosis in some cases. I think the other component is that people who are developing cognitive symptoms are often don't have a lot of insight into their deficits. And so it's often family members or friends who are bringing people into the office and expressing concern about those symptoms. And so I think that brings another layer of complexity in terms of caregiving and who is doing the caregiving.
Great. No, I appreciate that. That's very helpful. And it's good to see that those distinctions and whether that's a benefit or not, will yet to be seen. I want to pick up on a thread that I saw in a couple of different of the chat questions, and that was really about the importance of exercise or strength training or high protein diet. Are there other sort of nutritional or exercise factors in perimenopausal or postmenopausal women that might mediate the change in glucose that you could see that might have an impact on dementias?
Yeah, I don't know off the top of my head about if there have been studies that have looked specifically at kind of exercise and glucose utilization and whether that impacts the brain. I personally tell all of my patients that I see in clinic that staying physically active, socially active, and cognitively active are all good for your brain health, and that's true of
Mhm.
whether someone is having memory symptoms or whether that someone is in their midlife and going through menopause. um, so I think physical activity is beneficial for the brain and has lots of other kind of uh, consequences throughout the body that are that are beneficial. And I think there's increasing work looking at kind of these lifestyle modifications that seem to indicate that they do have a benefit for brain health as well.
That's terrific. I know, actually, we featured some speakers at the workshop that we heard from Dr. Green Parker earlier around exercise and diet. And the research is, you're right, it's not quite there yet. I think a lot to be learned, although you can make a good case that exercise and eating right is always good. Um,
Yeah.
Let me focus on one thing. You talked a bit about hysterectomy and how early or iatrogenic sort of menopause might have impacted on dementia. Um, and I'm just wondering, did the studies that you saw, and I'm going to do a follow-up that came from the chat, account for differences in the type of surgical menopause and the different hormonal implications, whether it was hysterectomy, unilaterally, oophorectomy? A couple people were really interested in those kinds of results. What do you think about that?
Yeah, I think it's an important kind of distinction because whether someone has hysterectomy or oophorectomy, and whether that is unilateral or bilateral, or whether it's removal of both the hysterectomy or removal of the uterus and the ovaries, those have very different implications for estrogen levels and hormone levels. And I think we as a field could do a better job of distinguishing between those different types of menopause and surgeries when we're looking at the relationship between various menopausal characteristics and cognition later in life. I think there's some evidence that even though a hysterectomy in and of itself won't, you're not removing the ovaries, but it does seem to have an impact on decreasing ovarian function. But again, that's a little bit comparing apples and oranges to the overall effect on hormone levels. And so it's something that we need to do more research on. And I think aging studies, I think it's an opportunity for us to really focus on those specific types of questions and trying to disentangle that when we're doing these types of studies.
Yeah, that's terrific. And I think that's really important. And there's so much interest in the chat around this, and especially just to sort of build on that a little bit. Any sense signals that, by really focusing on either, hormone replacement, actually, or really more menopausal hormone therapy for people who had a hysterectomy, did you see any signals that helps either with cognitive decline or Alzheimer's?
Yeah, I most of this is observational studies, and so it does seem like women who are going through surgical menopause prematurely may benefit from being on menopausal hormone therapy following that surgery until the time of their kind of average natural menopause. So I think there's
Yeah.
more evidence that there may be potential cognitive benefits for women who have gone through surgical menopause much earlier in life. Again, it's one piece of the puzzle, and I think you have to consider other impacts, whether that's cardiovascular disease or cancer risk and things like that. So it's complicated.
Yes, that's a good way to say it. It is complicated because I've seen a lot of interest in, where the use of hormonal therapies for cognitive decline and the other symptoms, the vasomotor symptoms and everything. And that really is some of the underlying challenges that we're facing. And when in a woman's path to menopause, through that transition in particular, I don't know if you have thoughts about where you see this going, or where are the really high quality or high impact research questions that we need to be asking? Do you have any sense for what are the most important ones? If you had to pick one or two questions out of all the things you've talked about today, what are the things we should really focus on, do you think, research-wise?
That's a good question. I think it would be interesting to have more data about the real world effects of these new anti-amyloid therapies
Yeah.
in men compared to women. Because again, as I mentioned, the studies were not designed to look at sex differences, but I think this is a very exciting time for the field of Alzheimer's disease and aging research because we now have these new disease modifying therapies. But I think we need to be we need to know whether they help everyone in the same way that we think they do, because otherwise, differences in outcomes and quality of life are going to widen if we're not careful about thinking about whether these treatments benefit everyone equally. So I think that's one area that I would be interested in having answers to, with the
Yep.
caveat that these are all very new, and so we're still gathering data.
Understood. And actually, you know what? I think that is a great way to, I think, leave us, because there are many questions that still need to be resolved. Actually, the excitement that you just mentioned, I feel, both around, the workshop that you heard about from Melissa earlier. We know there's a lot of interest at NIH on this topic and other places. And I think you've just highlighted one important area we need to focus on when we think about. So let me just offer my thanks to you, Dr. Peterson, for a great presentation. Let me offer my thanks to the audience. Fantastic chat going on there. Thanks for all your great questions. And with that, I'm going to hand it back to you, Valerie. So thank you.
Thank you, Bob. That was a very engaging and exciting discussion. Thank you again, Dr. Peterson. Thank you, Dr. Green Parker, for highlighting our Menopause P2P program. And I also want to thank the tech team and my ODP colleagues, Catherine, Mike, Renee, Wilma, Norma, and Denise, who work behind the scenes to make things possible. And thank you all for your excellent questions and for making time for us today. We do acknowledge that there may have been some connectivity issues throughout the programming, and we hope that you revisit this webinar recording once it's available on our YouTube channel in the coming weeks. And if you have any questions whatsoever about the webinar series or today's presentation, please feel free to reach out at preventionandfocus@nih.gov. This concludes today's webinar presentation. Thank you again. Enjoy the rest of your day.